Good morning, everyone. We're going to go ahead and get started. We have a packed meeting agenda today. Good morning and welcome to the October 2018 ACIP meeting. I'm Dr. Amanda Cohn. We are awaiting final approval of our new incoming ACIP members and our new incoming chair. Therefore, as the designated federal official, I will be chairing today's meeting, and I've asked Dr. Romero to assist me with that. We do have 11 voting members in attendance, so we do have a quorum. Next slide. The proceedings of the meeting are accessible to people not in attendance via the World Wide Web. Welcome to those who cannot attend the ACIP meeting in person. Stephanie Thomas and Natalie Green, who's in the back of the room right now, will be with us for the duration of the ACIP meeting to assist with meeting functions. And handouts of the slides to be presented have been distributed to the ACIP members, are available to members in the public at the back of the auditorium, and are available on ShareLink file for Liaison and ex officio members. And please let us know if you have any trouble accessing those. Slides presented at this meeting will be posted to the ACIP website approximately 3 to 4 weeks after the meeting, and the live webcast videos will also be posted about 4 weeks after the meeting. Meeting minutes are posted on the ACIP website, generally within 90 days of the meeting. The minutes from the June 2018 meeting are now available on the ACIP website. Next slide. The next ACIP meeting will be convened at CDC on Wednesday and Thursday, February 27th and 28th, 2019. Registration for all meeting attendees is required and will be open this Friday on the ACIP website. The registration deadline for non-U.S. citizens is January 30th, 2019, and for U.S. citizens, registration closes February 15th, 2019. Registration is not required for webcast viewing, and I just want to reiterate that especially for non-U.S. citizens, the registration deadline is final and you cannot attend if you do not register as an international citizen prior to that date. Next slide. I am pleased to announce that we have an updated ACIP website, and this was launched yesterday. We hope that everyone finds this new website easier to navigate and that we can locate information about ACIP more readily. Specifically, we're going to have a new section on ACIP workgroups, and over the next several months, we'll be adding information to that section on workgroup terms of reference, and we'll have a list of workgroup members for each workgroup available on this website. Next slide. We have one new ex officio member we'd like to welcome to the meeting today, Doran Fink from the FDA. And we have one new liaison representative we'd like to welcome today, Jason Goldman, who will be representing the American College of Physicians. Next slide. We have a couple of member substitutions for this meeting. Matthew Tunis will be representing NACI at this meeting. And we have two ex officio representatives. Lori Hoffman-Hogg will be representing the VA, and Tammy Beckham is representing MVPO at this meeting. Next slide. Topics presented at the ACIP meeting include open discussion with time reserved for public comment. Public comment period is scheduled immediately preceding each ACIP vote and at the end of the meeting day. We ask that public comments prior to a vote be related specifically to the vote being taken for that vaccine, and comments not related to the vote be held until the public comment session at the end of the day. People who plan to make public comments should visit the registration table at the rear of the auditorium and complete the public comment form and leave it on the table. We will collect these and log you in for public comment. Stephanie Thomas will record your name and provide you with information on the process. People who make public comments should provide 3 pieces of information: your name, organization if applicable, and the organization supporting your attendance at the meeting. Registration for public comment was also solicited in advance of the meeting through the Federal Register. Given time constraints, each individual is asked to limit their total comments to under 3 minutes. Comments not presented at this meeting may be submitted in writing for inclusion in the meeting minutes, and the ACIP voting members do have several letters that have been submitted prior to this meeting in their folder. Next slide. We do want to talk about some changes that will be made to the public comment process for the next meeting. As part of ACIP's continuous improvement process, we are making a few updates beginning at the February 2019 meeting. This information will be included in the Federal Register. These changes are intended to ensure that members of the public have ample opportunity to provide written and in-person comments and make the comment process clearer. The website and Federal Register notice will be updated with this new information. So changes to the in-person public comment process will include 30 minutes reserved at the end of each ACIP day, registration for in-person comment only at the meeting, so you do not need to register online prior to the meeting anymore, and then comments will be made in the order of the registration, time permitting. So at the end of the 30 minutes, we will no longer be able to take any additional public comment. I want to remind people that this 30 minutes is more than any public comment period that we've had in the last several years, so we think will be ample amount of time. Changes to the written comment process will include a new cdc.gov mailbox to receive all written comments, more flexible requirements for the format and the length of the written format, acceptance of written comments before, during, and immediately after the meeting, if you submit comments up to 48 hours in advance of the meeting, this will be provided to all the ACIP meetings, and then comments that are submitted within 24 hours of the ACIP meeting will be included in the meeting's official record. Next slide. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agreed to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on safety data monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to this. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of the meeting, during roll call, the ACIP members will declare any conflicts of interest. Next slide. Detailed instructions for submission of names of potential candidates to serve as ACIP members will be added to the ACIP website shortly. Applications for ACIP membership are due no later than July 1st, 2019, and this is for the 4-year term beginning July 2020. Next slide. So please turn off your cell phones to avoid disruption. And at this time, we are going to take a roll call of our current voting members. And at the time you announce yourself, please indicate whether or not you have any conflicts of interest for any of the topics that are being discussed at this meeting. And we'll start with
Chip Walter, no conflicts.
Paul Hunter, no conflicts.
Sharon Fry, no conflicts.
Robert Atmar, no conflicts.
Hank Bernstein, no conflicts.
Eche Ezanolun, no conflict.
David Stevens, no conflicts.
Kelly Moore, no conflicts.
Peter Szilagyi, no conflicts.
Grace Lee, no conflicts.
Jose Romero, no conflicts.
Great, thank you. So now we're going to introduce our ex officio members. We're going to start with Dr. Nancy Messonnier, and then we're going to start with the VA.
Nancy Messonnier, Director of the National Center for Immunization and Respiratory Diseases at CDC.
Lori Hoffman-Hogue for Dr. Jane Kim, Department of Veterans Affairs.
Tom Weiser, Indian Health Service.
Eric Dusing, Department of Defense.
Doran Fink, Food and Drug Administration.
Norine Nairn, Vaccine Injury Compensation Program.
John Vigo, Division Microbiology Infectious Disease at the NIH.
Tammy Beckham, Acting Director of the National Vaccine Program Office.
Great, thank you. And now we're going to introduce the liaison members. And Dr. Weber, could we start with you and then go around?
David Weber for Society for Healthcare Epidemiology of America.
Amy Middleman for the Society for Adolescent Health and Medicine.
Sean O'Leary for the Pediatric Infectious Diseases Society.
Pat Whitley-Williams, National Medical Association.
Corey Robertson, Pharmaceutical Research, Manufacturers of America.
Patsy Stinchfield, National Association of Pediatric Nurse Practitioners.
Good morning, Jeff Duchin, National Association of City and County Health Officials.
Bill Schaffner for the National Foundation for Infectious Diseases.
Kathy Newsel, the Infectious Diseases Society of America.
Christine Hahn, the Council of State and Territorial Epidemiologists.
Stan Grogg, American Osteopathic Association.
Steve Foster, American Pharmacists Association.
Chris Finley, Association of Immunization Managers.
Chad Riddle, American Nurses Association.
Rebecca Coyle, American Immunization Registry Association.
Mark Natowski, America's Health Insurance Plans.
Ken Schmader, American Geriatric Society.
Sandra Freihofer, the American Medical Association.
Jason Goldman, American College of Physicians.
Carol Hayes, the American College of Nurse Midwives.
Susan Even, American College Health Association.
Marie-Michelle Léger, American Academy of Physician Assistants.
David Kimberlin, American Academy of Pediatrics, Red Book.
Bonnie Maldonado, American Academy of Pediatrics, Committee on Infectious Diseases.
Pamela Rockwell, American Academy of Family Physicians.
Great, thank you. So now that we've had everybody introduce themselves, I think we're ready to begin the first session. Our first session today is hepatitis A vaccines, for which we have scheduled a vote. So we'd like to call up Dr. Kelly Moore to introduce the group.
Good morning, everyone. It's my pleasure to be the chair of the Viral Hepatitis Working Group. All right, the terms of reference for our working group with respect to hepatitis A are to update the hepatitis A recommendations of the ACIP originally published in 2006, and also to address homelessness as an indication for routine immunization against hepatitis A. Between February and October of this year, we had 4 meetings of the work group focused on homelessness as an indication for routine vaccination. We discussed hepatitis A and homelessness in San Diego County, California, and the experience they've had between 2016 and 2018. And then we had presentations to the work group and discussion of the evidence to recommendation framework and grade that you'll hear more about later in this session. On today's session, we will discuss homelessness as an indication for a routine hepatitis A vaccination with a background presentation and a presentation of the evidence to recommendation framework, followed by a summary of the information and a vote. The next steps of the working group are to have a publication coming out on November 2nd. This MMWR policy note will update the ACIP recommendations for use of hepatitis A vaccine for post-exposure prophylaxis and for pre-exposure prophylaxis for international travel. We'll also later on be presenting the full updated hepatitis A vaccine statement for a vote, and we will continue our deliberations on adult hepatitis B vaccination topics. I want to acknowledge the great work of our work group members and the tireless round-the-clock leadership of our SME and work group lead, Dr. Noel Nelson. And also to acknowledge the CDC staff from across several divisions and centers who have contributed to our work, especially highlighting Dr. Mona Dashani, who we'll hear from later today. Thank you very much, and I'll turn it over to Dr. Nelson.
Thank you, Dr. Moore, and good morning. So I'm going to give a background for this session. Today I'm going to present background information on hepatitis A epidemiology, hepatitis A vaccines, the ongoing hepatitis A outbreaks, a study of hepatitis A among homeless in San Diego, and discuss homelessness in general. Data collection for hepatitis A started in 1966. The highest number of hepatitis A cases reported was in 1971, about 60,000 cases, at a rate of about 30 cases per 100,000 population. Vaccine was recommended in 1996. From 1996 to 2011, there was a 95.5% decrease in reported cases. The number of reported cases has fluctuated slightly since 2011, primarily due to outbreaks. In 2016, there were 2,007 reported cases. Rates of reported hepatitis A reached a low point in 2014 for all age groups except those aged 10 to 19 years, for which the low point occurred in 2015. Rates increased for all age groups from 2015 through 2016, except for those aged 0 to 9, whose rates remained stable. When comparing the 2016 hepatitis A rates of all age groups, persons aged 20 to 29 years and 30 to 39 years had the highest rate at 0.9 cases per 100,000 population, and persons aged 0 to 9 years had the lowest rate at 0.1 cases per 100,000 population. The prevalence of antibody to hepatitis A virus by age group is shown for 2009 to 2010 based on data from the National Health and Nutrition Examination Survey, or NHANES. Compared to previous surveys, significant increases occurred in the proportion of children with protection for ages 6 to 11 years and age 12 to 19 years, most likely due to vaccination. However, significant decreases occurred in the proportion of adults with protection for ages 40 to 60 years and older. Overall, the prevalence of antibody among U.S. residents is about 26.5%, indicating that less than 1/3 of the U.S. population had protection against hepatitis A infection in 2009 to 2010. Now I will talk about the hepatitis A vaccines. There are 2 inactivated single-antigen hepatitis A vaccines licensed in the U.S. Havrix was licensed in 1995 and Vacta in 1996. In a clinical trial, the efficacy of Vacta in protecting against clinical hepatitis A was 100% among greater than 1,000 New York children aged 2 to 16 years who received 1 dose while living in a community with a high hepatitis A virus disease rate. The efficacy of Havrix in protecting against clinical hepatitis A was 94% among greater than 38,000 Thai children aged 1 to 16 years who received 2 doses 1 month apart while living in villages with high hepatitis A viral disease rates. A combined hepatitis A, hepatitis B vaccine, Twinrix, is also licensed and available in the United States. In pre-licensure trials, adverse reactions to Havrix, Vacta, and Twinrix were mostly injection site reactions and mild systemic reactions. Post-marketing surveillance for adverse events following receipt of hepatitis A vaccines has been performed primarily by 2 systems in the United States, the Vaccine Adverse Event Reporting System, VAERS, and the Vaccine Safety Data Link, VSD. No unusual or unexpected safety patterns were observed for any of the hepatitis A vaccines licensed in the United States. Hepatitis A vaccination was introduced incrementally in the U.S. from 1996 to 1999. In 1996, vaccine was recommended for children at age 2 years in communities with high rates of disease and children through teen years in outbreaks. In 1999, vaccine was recommended for children at age 2 years of age in 11 states, shown in purple, with average annual hepatitis A rates of 2 times the national average. Vaccine was considered in 6 states, shown in the lighter shade, light purple, with rates above the national average. In addition, groups at increased risk of hepatitis A viral infection or severe hepatitis A viral disease were recommended to receive hepatitis A vaccine. Those include travelers, men who have sex with men, users of injection and non-injection drugs, persons with clotting factor disorders, persons who work with non-human primates, persons who anticipate close personal contact with an international adoptee, and persons with chronic liver disease. Today, we will discuss workgroup deliberations regarding adding homelessness as an indication for vaccination. The single antigen hepatitis A vaccine is recommended to be administered as a 2-dose series, at least 6 months apart. The antibody to hepatitis A virus has been shown to persist in vaccine recipients for at least 20 years in adults administered inactivated vaccine as children with a 3-dose series. Subsequent studies have shown that this 3-dose series is equivalent to the 2-dose schedule given today. At least 20-year antibody to hepatitis A viral persistence was demonstrated among adults vaccinated with a 2-dose schedule as adults. Detectable antibodies are estimated to persist for 40 years or longer based on mathematical modeling and antibody to hepatitis A viral kinetic studies. Protection following natural infection is lifelong and may also be following vaccination. The antibody to hepatitis A virus after a single dose of hepatitis A vaccine can persist for almost 11 years. A single dose of hepatitis A vaccine was shown to promote hepatitis A viral-specific cellular immunity similar to that induced by natural infection. The hepatitis A vaccine coverage in 2016 is as follows. The greater than equal to 2-dose coverage was 60.6% for children aged 19 to 35 months. This is likely underestimated since the first dose can be given up to age 23 months, which is the second dose administered at least 6 months after the first. The greater than equal to 1-dose coverage was 86.1% for children aged 19 to 35 months. Similar vaccine coverage was recently published for 2017. The greater than equal to 2-dose vaccine coverage for adults was much lower, with 9.5% for adults greater than equal to 19 years. And 13.4% for adults aged 19 to 49 years, 19% for travelers, and 24% for those with persons with chronic liver disease, both recommended risk groups for hepatitis A vaccine. And the rate was even lower at 5.4% for adults greater than equal to 50 years of age. Now I will talk about the ongoing hepatitis A outbreaks. Prior to 2016, there had not been a large multi-state hepatitis A outbreak in the United States since the 2013 outbreak associated with frozen pomegranate arils, and there had not been a large person-to-person community-wide outbreak since 2003. In 2016, 2 outbreaks associated with contaminated food items imported from hepatitis A endemic countries occurred, followed by community-wide person-to-person outbreaks that continue to this day. Over 7,000 outbreak cases have been reported in this time, and staff have been sent to multiple states, and the Division of Viral Hepatitis Laboratory has sequenced over 2,500 specimens. So why is this happening now? In the past, large community outbreaks were associated with asymptomatic children infecting the adults who cared for them, who then transmitted the virus to other adults. With the widespread adoption of the universal childhood vaccination recommendations, asymptomatic children are no longer the main drivers of outbreaks. Although the overall incidence rate of hepatitis A infection has decreased within all age groups, most adults are not immune because they have not been vaccinated and were not infected naturally. Therefore, susceptible adults are exposed through contaminated food or through behaviors that increase risk of infection. Older adults are more likely to be symptomatic and experience severe disease and adverse outcomes such as hospitalization, fulminant liver failure, and death. For the at-risk adults with which vaccination recommendations do exist, uptake is low. The Division of Viral Hepatitis Outbreak website map is shown here. 12 states are currently considered part of the state-specific hepatitis A outbreak. Massachusetts and North Carolina were recently added. Looking at the case counts of hepatitis A virus outbreak among the persons who report drug use and or homelessness, based on mostly publicly available data up to October 19th, 2018, you can see that the total number of cases in the affected states is about 7,500, with over 4,000 hospitalizations, or 58% of the cases, and 74 deaths. In comparison, in the multi-state outbreak associated with pomegranate arrows in 2013, there were 162 cases in 10 states, with a lower 44% hospitalization rate and no deaths. The death rate for this outbreak is very high, likely due to co-infection with hepatitis B and hepatitis C, and poor immune and health status of the persons infected. Most of the affected states with ongoing transmission provided numbers of homeless persons infected with hepatitis A virus. The data are shown here. The methods used to generate homeless counts and the availability of risk factor information varies among states. Homeless persons have made up a large percentage of the cases, particularly in California, considering the total hepatitis A viral cases, including cases with injection or non-injection drug use, with over 40% of cases being homeless in San Diego, Utah, and over 10% of cases in Michigan, West Virginia, Tennessee, and Kentucky, in states that report risk factor information. So the states that I just mentioned with the with about 10%, that also includes the homeless and injection drug use, which are the main drivers of this outbreak. Of note, Massachusetts also reports 58% homeless among outbreak-associated cases. If you look at cases among homeless only, the rates are lower, with 7.5% in Utah, 15% in San Diego, 15% in California and San Diego. There has been increased case morbidity and mortality reported in these outbreaks, with hepatitis A-related hospitalizations increasing prior to 2016 from 7% in 1999 to 46% in 2015. Hospitalizations related to outbreaks during 2016 to 2018 ranged from 25% in the foodborne outbreak associated with frozen scallops to 81% in the Michigan outbreak associated with drug use and homelessness. All-age mortality for hepatitis A viral infection is typically less than 1%. The case mortality in outbreaks associated with homelessness and drug use are around 3%. We're currently seeing 3 to 13% of cases co-infected with hepatitis B virus and 17 to 61% co-infected with hepatitis C. The increased mortality is likely due to acute or chronic infection of an already damaged liver. There is no indication that there is increased virulence in the circulating outbreak strains. Little is known about hepatitis A virus immunity among homeless populations in the United States. Hepatitis A virus infection is found at high frequency among persons who use drugs in these outbreaks as well. Hepatitis A virus is transmitted primarily by the fecal to oral route. Close contact and poor hygiene conditions are likely to play the principal role in driving these outbreaks. So how do we stop these outbreaks? Reduction in new cases can be obtained and sustained by maintaining a high level of population immunity through vaccination. Historically, the spread of hepatitis A was controlled through vaccinating contacts of cases. This is shown to be limited in these recent outbreaks, as persons are frequently unaware of exposure and cases may be reported to public health authorities too late for post-exposure prophylaxis to be effective. We are recommending proactive vaccination of groups at highest risk in specialized venues, since outreach to people who use drugs and homeless can be challenging for many reasons, including mistrust and limited access to routine medical care. Ideally, these groups should be identified and targeted early in the outbreak, but this can be logistically difficult and costly. So primary prevention, ensuring vaccination of these risk groups before outbreaks occur, is definitely preferable. In 2017, the large outbreaks of hepatitis A among adults in several U.S. cities resulted in increased demand for vaccine, resulting in constrained supplies. In response, CDC responded by working with public health officials in affected jurisdictions, collaborating with manufacturers, implementing ordering controls, and increasing vaccine availability on CDC's adult vaccine contracts. As available vaccine supplies have increased, and progress has been made regarding ongoing outbreaks, the public sector vaccine supply strategy has evolved. Additional vaccine has been made available for unaffected jurisdictions to facilitate routine vaccination activities. And while manufacturers have supplied to meet current demand, CDC and vaccine manufacturers continue to monitor ongoing demand for and usage of adult hepatitis A vaccine closely. I will now talk briefly about the vaccine outbreak response in San Diego to give you an idea of the magnitude. 2,538 total hepatitis A vaccination events occurred in San Diego at 833 points of dispensing events, 80 mobile van events, and 1,625 foot team events. Total hepatitis A viral vaccinations administered in San Diego County from March 6th through January 23rd were 121,921. The total at-risk population vaccinated was 103,000. In jails, vaccinations occurred through January 23rd and included 8,335 vaccines. A study done in San Diego by Dr. Corey Peak and Dr. Eric McDonald were analyses of homelessness as a risk factor. They looked at hepatitis A viral transmission, and they assessed that by doing a test-negative case control study, and elevated disease severity was assessed by a cohort study. The conclusions from the study were that vaccine indication was unrecognized for greater than 25% of patients reporting homelessness, meaning that greater than 25% of patients reporting homelessness did not have an already recommended risk group for vaccination. Homelessness was independently associated with a 2 to 3 times higher odds of infection and 2 to 4 times higher odds of severe outcomes of infection, specifically hospitalization or death. A number of limitations were noted in these analyses, including incomplete list of comorbidities such as chronic liver disease, and that homeless may be preferentially hospitalized. So how do we assess the cost of outbreak response? The cost of these ongoing outbreaks is not known at this time. However, San Diego spent about $12.5 million as of the end of April 2018 on the outbreak response, and other states have spent millions of dollars as well. For example, Michigan has so far spent about $7.1 million. This does not fully include staff time for individuals who work outside of our immediate preparedness area. Additionally, does not include any costs incurred directly by the local health departments prior to having received hepatitis A funding. In Kentucky, Louisville has spent about $2.1 million, and also has had numerous staff working on the outbreak full-time for about 9 months. Many of the local health departments have invested significant amount of staff time in responding to the outbreak locally. And many staff are not working extra time, but setting time aside from their regular public health duties to respond to the outbreak. In addition, there's hospitalization expenses, as I mentioned, diversion of human and financial resources from other activities, and homeless are involved in propagating the outbreak as well as drug users, even if all of the costs are not associated with homeless. So now I'll briefly talk about homelessness. So there are many definitions to homelessness. There's not one official definition. Different agencies use different definitions, which affect how various programs determine eligibility for individuals and families at the state and local level. Health centers funded by the U.S. Department of Health and Human Services use the HHS definition in providing services, which is shown on this slide. A homeless individual is defined as an individual who lacks housing without regard to whether the individual is a member of a family, including an individual whose primary residence during the night is a supervised public or private facility, example, a shelter, that provides temporary living accommodations, and an individual who is a resident in transitional housing. A homeless person is an individual without permanent housing who may live on the streets, stay in a shelter, mission, single-room occupancy facilities, abandoned building or vehicle, or in any other unstable or non-permanent situation. Estimates of numbers of homeless persons are determined by the Housing and Urban Development, or HUD, and these data from the 2017 Annual Homeless Assessment Report are as follows. On a single night in January 2017, state and local planning agencies reported 553,742 people were homeless, representing an overall 0.7% increase from 2016. Most homeless persons, about 360,000, were located in emergency shelters or transitional housing programs, while 192,000 persons were unsheltered. So homeless are categorized as individuals, people and families with children, unaccompanied homeless youth, veterans, chronically homeless individuals, and they're categorized as sheltered or unsheltered. Counts are listed for some of the currently affected outbreak states. In these states, individuals are the majority of persons who are homeless, and sheltered are a larger percent, up to 90%, than unsheltered, except for California, where unsheltered is 68% and sheltered is 32%. Looking at the last line on this slide, the total numbers for the U.S., the majority of homeless are sheltered, 65%, and are categorized as individuals. People experiencing homelessness experience diseases at higher rates than domiciled persons, including higher rates of chronic conditions, acute illnesses, and behavioral health issues. Conditions are more difficult to treat for a person experiencing homelessness. Problems with health sometimes leads to homelessness, and homelessness leads to and exacerbates health issues. Persons who are homeless experience greater barriers to accessing care as well, such as lack of a stable address, difficulty with transportation, uninsured or public insurance, and need to prioritize basic survival, such as food, shelter, and safety, before health care. So how do homeless persons experiencing homelessness access health services? The National Healthcare for the Homeless Council is a membership organization that provides training and technical assistance to 300 healthcare for the homeless federally qualified health centers and 90 medical respite programs. Medical respite program provides homeless individuals a safe place to recover from acute injury or illness. The map here shows the healthcare centers providing care for the homeless. The National Healthcare for the Homeless Council shares best practices among the community, conducts research, and advocates for policies to eliminate homelessness. At least one healthcare for the homeless program exists in each state, DC, and Puerto Rico. Healthcare for the homeless programs meet all the requirements of FQHCs and must conduct outreach and provide and or have strong linkages to mental health and substance abuse services. Healthcare for the homeless in 2018 had over 300 sites delivering care to over 850,000 individuals. The Healthcare for the Homeless programs provide primary care, behavioral health, and support services to people who are homeless regardless of their insurance status or ability to pay. And they also have requirements for outreach, such as shelter-based care, mobile clinics, and street clinics, which they have in over 30 metropolitan areas. So how is healthcare for the homeless paid for? So 90% of healthcare for the homeless clients are less than 100% of federal poverty level, and 64% are insured. So in 2016, in 295 healthcare for the homeless programs provided care to about 934,000 patients. Of these, 51% are in Medicaid, 4% Medicare and Medicaid, 4% other Medicare, 5% private, and 36% insured. However, 25%, only 25% are uninsured in expansion states. So for uninsured, referral to specialty care is limited. However, basic services are provided. And there's a decrease in uninsured since Medicaid expansion. There's a wide variation in outreach and enrollment activities across states, but Medicaid is the largest source of insurance for health care for the homeless patients overall. As states continue working to reduce health care disparities and improve health, access to comprehensive health insurance remains a key factor in access to care. So how would routine vaccination of homeless persons for hepatitis A be implemented? So vaccination would be integrated into vaccination clinics that serve vaccination would be integrated into clinics that serve the homeless, including FQHCs, community health centers, shelters, mobile clinics, and street clinics. This would provide a familiar setting for many homeless. The providers would be experienced in caring for persons who are homeless. There would be an opportunity for education in these settings and access to other preventive and health services. So other considerations that were discussed by the work group: what is the number of persons who need to be vaccinated to stop transmission or halt an outbreak? The exact number is not known, but a few studies have explored the question. A study in Israel found that less than 10%, a study in Israel that looked at trends in disease incidence after implementation of universal vaccination among children found that less than 10% of the rest of the Israeli population was immunized during the study period. The overall incidence of hepatitis A declined by nearly 90%. Among children aged 5 to 14 years, an estimated 81% decline occurred at a time when vaccination coverage had reached 25%. Vaccine demonstration project conducted in California in 1995 to 2000 showed an incidence of reported hepatitis A cases dropped by 93%, despite immunization coverage of only 60%. And a study in Alaska looking at stopping an outbreak found that 80% vaccine coverage was needed to stop the outbreak. So it's challenging to determine the herd immunity thresholds for routine vaccination among specific risk populations, such as homeless, persons who use drugs, or MSM, or other risk groups. However, these studies have shown that at low rates of routine vaccination, transmission can be slowed. So how much would it cost to vaccinate homeless? A cost-effectiveness analysis was not performed for homelessness as an indication for vaccination. However, states are in the process of assessing the cost for ongoing outbreaks, as I previously mentioned, which include vaccination of injection and non-injection drug users as well, and already recommended risk groups. Vaccine administration fees range from a few dollars to up to about $20 based on best available information. And vaccine refusal rates for influenza and hepatitis A in homeless shelters in San Diego range from about 15 to 20%. Refusal rates were observed anecdotally to be higher in jails and emergency departments. So considering the current prices of single antigen and combined vaccine, if you consider that about 550,000 persons in one night are experienced homelessness in 2017, including youth and veterans, a very basic calculation would be to look at the 550,000 times the price of a single dose of vaccine, or times 2 for a series completion, including a small administration fee, which would be $16,500,000 or $33 million respectively. However, we know that the uptake will not be 100% and that not all homeless will be vaccinated at the same time. So that cost would be spread out over time. Another consideration is that the homeless population is dynamic, with people entering and leaving the risk population with an ongoing need for protection. And the chronic homeless population is much smaller, about 87,000, than the single night total, In addition, many of those 87,000 already have another indication for hepatitis A vaccination, such as drug use. So in an outbreak response, the cost associated with and healthcare expenses and deferred activities is substantial. As noted, $12.5 million for San Diego. So in summary, hepatitis A vaccine is largely responsible for the marked reduction in hepatitis A cases. There's an increasing proportion of adults in the United States are susceptible to hepatitis A due to low two-dose vaccination coverage, decreases in antibody to hepatitis A viral seroprevalence, and reduced exposure. The ongoing outbreaks demonstrate a shifting epidemiology, person-to-person transmission among unvaccinated vulnerable populations, such as homeless. Community outbreaks are often prolonged and challenging to control. And vaccination is a cornerstone of outbreak control of community outbreaks, with outreach and vaccinations of persons at risk in targeted venues effective outbreak control. However, routine vaccination of hepatitis A viral risk groups is critical for outbreak prevention. And I would like to acknowledge all the people that have contributed to these data and that we've worked with over the last year and a half, including our incident management team in the Division of Viral Hepatitis and the states affected.
Great, thank you. I think we're going to hold on questions until after the next presentation and move on to Dr. Dashani.
Good morning, everyone. I will be walking through the ACIP Evidence to Recommendations framework for homelessness as an indication for hepatitis A vaccination. The components of the framework that we will be looking at today are the policy question, background information. We will look at how the evidence was obtained. We will address a set of 10 criteria, and finally summarize our findings and conclude with a recommendation. So let's begin with the policy question. The policy question is, should routine inactivated two-dose hepatitis A vaccination be recommended for protection against hepatitis A among persons experiencing homelessness? To address this, we looked at PICO. Here, the population is homeless, all ages. The intervention is inactivated hepatitis A vaccine administered as a two-dose series. The control group is unvaccinated homeless individuals. And finally, the outcome is divided into benefits and harms. Under benefits, we looked at reduction in disease burden and protection against hepatitis A-related disease. And under the harms outcome, we looked at local reactions and systemic adverse events, such as anaphylaxis and transient purpura. Next, we will look at some background information in brief. Dr. Nelson has already provided a detailed background information in her earlier presentation on the epidemiology of hepatitis A and homelessness. In the United States, approximately 3 million persons, that is 1% of the population, are homeless in a given year. Rates of homelessness have been increasing for the last decade. Men, women, and children of all ages and ethnicities have been affected. In 2017, in a single night, approximately 550,000 people experienced homelessness, where 65% were staying in emergency shelters, transitional housing programs, and safe havens, and 35% were in unsheltered locations. A study by Gambatis in 2013 indicated that individuals experiencing homelessness have an increased risk of mortality that is ranging from 1.5 to 11.5 times greater than the risk in the general population. It has been seen that community health centers, which provide comprehensive preventive and primary health services, serve as a basic platform to provide vaccination to meet the specific needs of the homeless. Recently, the National Healthcare for Homeless Council, which is an organization comprised of a network of physicians, nurses, social workers, and advocates, all sharing a mission to eliminate homelessness, presented on the importance of the Medicaid expansion in 34 states, and mentioned that 3 additional states are planning on expanding Medicaid coverage, which will provide an opportunity to increase Hep A vaccine coverage and access to care and treatment services among the homeless. Studies have shown that congregate living conditions increase the risk of hepatitis A transmission in the homeless, which can result in outbreaks that we are seeing nowadays. We will now look at some background information on vaccinations among homeless. Vaccinations are critical to the prevention of disease in such individuals. A large number of homeless individuals are not protected from vaccine-preventable diseases due to limited access to healthcare or low rates of insurance coverage. Hepatitis A vaccine has proven to be effective. Studies have shown that vaccine-induced antibodies can persist for more than 20 years in adults, and there is a good mathematical evidence that estimates that antibodies can persist for more than 40 years or longer. Even though evidence suggests that appropriate shelter or shelter-based interventions for targeted populations are the most efficient methods for mass vaccination of the homeless, a study by Badiga in 2008 mentions that national public health programs specific to the homeless are required, and strongly recommends systematic vaccination against hepatitis A virus, along with hepatitis B, influenza, and others. The study by Smith in 2016 and the medical societies, such as the American Academy of Family Physicians, state that vaccines are a cornerstone in preventing spread of infectious disease and in the prevention of future disease in the homeless population. Smith further states that maximizing the immunization rate among the homeless is critical in order to prevent outbreaks in the shelter and for the greater community at large. This slide displays some of the seroprevalence studies that we found. Very little information was available among the homeless. I would like to point out the first study on the first row, which is the Hennessy study, which took place in San Francisco. The study looked at 1,138 homeless individuals, where 6% were less than 35 years of age, 67% were 35 to 45 years, and 23% were greater than 45 years of age. This was the only published study that identified homelessness as an independent risk factor and looked at antibodies to hepatitis A virus by years of homelessness. Less than 1 year, the seroprevalence was 46%, 2 to 4 years, it was 50%, and greater than 5 years, it was 61%. Next, we will look at the evidence retrieval. We conducted a systematic literature review for hepatitis A vaccine and homelessness, and did a search in PubMed, Embase, and Medline from a period of January 1st, 2000 through April 25th, 2018. Here are the search terms that we included. We excluded any articles in animals. There were no language restrictions on our initial searches, and articles from all countries were included. Here is a flowchart of our search results. We will start from the left and then move down and then to the right. There were a total of 582 abstracts, of which 288 were duplicates, and 21 articles dated prior to the year 2000 were excluded. This left us with 273 unique abstracts that we reviewed. And out of those abstracts, 35 full articles were reviewed, and 4 articles were included in our grade analysis. We excluded articles dated earlier than the year 2000. Vaccines not licensed in the U.S. were excluded. Articles that didn't address the population of interest, in this case homeless. And finally, data that couldn't be abstracted were also excluded. The next few slides, we looked at 10 criteria, and each one of them had 2 components, judgment and research evidence. We will present our findings on the judgment and provide some research evidence to support the decision of our judgment for each of the criteria. Criteria 1. Is the problem a public health priority? We said yes, and some of the evidence we found is homeless people face many barriers to accessing healthcare systems, and these factors contribute to the increasing spread of infections. An article from Wong mentions implementing efficient strategies to prevent the spread of communicable infections among the homeless should be a public health priority. Homelessness has been associated with enormous health inequalities, including shorter life expectancy, higher morbidity, and greater usage of acute hospital services. The National Healthcare for Homeless Council report indicated that homeless persons are 3 to 6 times more likely to become ill when compared to the general population, and their hospitalization rates are 4 times higher, and they are about 3 to 4 times more likely to die at a younger age. A study from Barrel published in Boston reports that overuse of emergency service leads to higher costs for treatment among the homeless. A quarter to 1/3 of homeless individuals are hospitalized during a given year, and these individuals are 3 times more likely to utilize the emergency department than the general population. It has been seen that vaccinations are an important public health measure for infectious disease control, yet are often not accessible to some of these most vulnerable adults. We know insurance coverage varies by states. However, with the Medicaid expansion in 34 states and 3 additional states to offer Medicaid expansion, we hope that it may provide an opportunity to make available routine hepatitis A vaccination and increase access and care to treatment for persons experiencing homelessness. Furthermore, outbreak investigations have shown that people experiencing homelessness are at higher risk of infection and higher risk of severe outcomes from infection. During a large outbreak of hepatitis A in San Diego County, more than 1/4 of the homeless were not covered by the current indications for vaccination. Of the approximately 600 reported cases, homelessness was identified as an independent risk factor for hepatitis A virus transmission in 163 cases, and this was from an unpublished study by Dr. Corey Peak. In Maricopa County, Arizona, an article published by Everson mentions that expeditious vaccination slowed the spread of hepatitis A outbreak. And another study looked at hepatitis A outbreak in Bristol in United Kingdom. There were a total of 123 cases, of which 4 people died and 39 were hospitalized. This table looks at the case counts of hepatitis A outbreak among persons who report drug use and/or homelessness. Dr. Nelson provided an updated slide which included Massachusetts and North Carolina. But I just want to emphasize on the number of deaths and hospitalizations that resulted due to this multi-state hepatitis A outbreak that we are seeing in the United States. We will wrap up criteria 1 from a study by Kushel published in 2018, which addresses the root cause of hepatitis A outbreak in the homeless. The study discusses the importance of vaccinating and educating the homeless in containing the outbreaks and states that more needs to be done to address the underlying cause. Criteria 2. How substantial are the desirable anticipated effects, that is, the beneficial effects of vaccination? We said the beneficial effects of vaccination are large. Vaccination programs are an important component of public health initiatives and preventive medicine. Hepatitis A vaccine has been shown to be highly effective and is a well-understood vaccine over the years, where a 2-dose inactivated hepatitis A vaccine can induce protective efficacies of more than 90%. The effectiveness of inactivated hepatitis A vaccine in a large-scale immunization program in North American populations resulted in a 94 to 97% reduction in the incidence of acute hepatitis A within 6 to 10 years. Hepatitis A has been shown to be effective in ending and controlling outbreaks in the homeless as well. An outbreak of hepatitis A in Southern California, where 90,000 doses were distributed, was a key to ending the outbreak. A study published by Polis stated that completion rates were reasonable in a vaccination program in the homeless population. The study concluded that if vaccination was offered as part of a standard care to the homeless, as opposed to part of a research project, the completion rates would have been much higher among this clinic population. The study by T-John among the homeless and drug users in Netherlands mentioned that contact tracing was very difficult in this hard-to-reach group, so a mass immunization campaign over a 2-week period was carried out. The campaign successfully vaccinated 83% of the homeless people and was effective in stopping the outbreak. And finally, a study by Wetherill demonstrated that immunizations can be successfully delivered to high-risk inner-city populations in non-traditional settings. Criteria 3. How substantial are the undesirable anticipated effects, that is, the serious adverse events? We said the serious adverse events for hepatitis A vaccine are minimal. Hepatitis A vaccine is considered to be highly immunogenic, safe, and effective. Studies by WHO and the Institute of Medicine found no severe adverse events to be causally linked to hepatitis A vaccine. And hepatitis A vaccine has been recommended to reduce hepatitis A case fatalities as well. The studies that were available among the homeless that we found reported no serious adverse events. A study by James, which looked at adverse events, reported no vaccination reactions. And another study by T. John in Netherlands indicated 4 cases of jaundice were seen despite vaccination, suggesting the author felt they were likely already infected at the time of vaccination. Criteria 4. Do the desirable effects outweigh the undesirable effects? We said yes. We know hepatitis A vaccine is highly immunogenic, provides lasting protection in healthy individuals, and generates protective level of antibodies also in patients with chronic liver disease or who have an impaired immunity. Analysis of data accrued over 2 years from the U.S. Vaccine Adverse Event Reporting System from 1995 to 96 showed only 428 adverse events following administration of at least 6 million doses. Only a few unexpected hepatitis A vaccine-associated serious events were reported, about 93 cases, thus reaffirming the safety of hepatitis A vaccine. Another study looked at post-licensure evaluation of the safety of VACTA in children and adults, where more than 49,000 doses of hepatitis A vaccine was administered. There were no health problems linked to the vaccine. An article published by Andre mentioned that a review of 104 clinical studies in 27 countries where over 50,000 subjects were given 120,000 doses of hepatitis A vaccine. About 50% of individuals who received the vaccine reported no symptoms, and in the remaining 50% who reported side effects, the main side effect reported was a mild and transient local soreness at the site of injection, which resolved spontaneously. Before we move on to criteria 5, I would like us to take a look at the PICO format again, which was used to grade the evidence. Criteria 5. What is the overall certainty of the evidence for critical outcomes? We did a great analysis and looked at 4 studies. We divided the outcomes into 2 categories, benefits and harms, and looked at the importance in each of those categories. Under the benefits, we stated the reduction in disease is critical, and under harms, any serious adverse events we stated is critical as well. The first outcome, which is reduction in disease burden, we found one study from Polis, which was published in 2010 in Australia. It was a clinical trial where they immunized 201 homeless individuals whose mean age was 42 years. A single dose of Havrix, 1,440 international units, was given at a federally funded clinic. There was no comparison group, and the main outcome seen was that the outbreak was controlled, but there was no mention on the reduction of cases seen after vaccination. Outcome 2, which is serious adverse events, we looked at 4 studies. The first study by Polis, which was published in 2010 in Australia that we talked in the earlier slide, didn't mention anything on adverse events. The second study by James in 2009 in Boston, United States, was an observational study. 122 homeless, substance users, and incarcerated persons aged greater than 21 years of age were given a hepatitis A vaccine at the emergency department. The name of the vaccine and the dose is unknown. There was no comparison group, and there was no reported serious adverse reactions or events. The next study by T. John, published in 2005 in Netherlands, was an observational study where 1,515 homeless individuals whose mean age was 42 years were immunized with the hepatitis A vaccine. The name of the vaccine and dose was unknown. There was no comparison group. And under main outcomes, the author reported 4 jaundice cases were seen after vaccination. And he stated that this was probably due to vaccine failure, and persons may already have been infected at the time of vaccination. And finally, the last study by Weatherill, published in 2004 in Canada, was also an observational study where 3,542 vulnerable adults were immunized, whose mean age was 46 years and mainly were males. Havrix was given, the dose was unknown, there was no comparison group, and in the early 2000s, they reported no adverse events. And in the fall of 2000, where multiple vaccines were administered, such as influenza, Hep A, and pneumococcal, they found 3 cases of anaphylaxis and 8 cases of oculorespiratory. This slide displays the evidence type 1 to 4 for grade based on the study design and quality. Randomized controlled trials or overwhelming evidence from observational studies were categorized as type 1. Randomized controlled trials with important limitations or exceptionally strong evidence from observational studies were categorized as type 2. Randomized controlled trials with notable limitations and observational studies were a type 3. And finally, randomized controlled trials with several major limitations and observational studies with important limitations were categorized as a type 4. This table summarizes the evidence type for benefits and harms. For the outcome reduction in disease burden, we had only one study, which was in Australia. Even though it was a clinical trial, we had no comparison group. There was a serious risk of bias, inconsistency, indirectness, and imprecision. Hence, we downgraded it to the evidence type of 4. Because we had only one study and no data available on the comparison group, we were unable to determine the estimates of effect and were not able to complete our grade analysis in determining the overall quality of evidence. For the outcome adverse events, we had 1 clinical trial and 3 observational studies. The studies were weak and didn't have comparison groups. Hence, evidence type was downgraded to a 4, and we rated the overall quality of evidence as very low using our judgment criteria, as we were unable to compare the estimates of effects across the studies. We had no confidence intervals or relative risk information for us to determine this. So looking at the limitations of our grade analysis, the 1 clinical trial study that we found in the homeless had many limitations. The study didn't provide details on its design and how it was executed, and there was no comparison or control group. The observational studies had several limitations as well, and some studies didn't report any quantitative data. There was only 1 study on immunogenicity of the vaccine, but it was in the non-US population. And finally, studies didn't look at homelessness as a risk factor in isolation. Criteria 6. Does the target population feel that the desirable effects are large relative to the undesirable effects? We said this varies. Even though little evidence is available on the values and perceptions of vaccination among the homeless, expert opinion by the ACIP Workgroup members and medical societies put forward that routine ongoing vaccination by providers with established relationships will be better accepted than vaccination by unfamiliar public health professionals during a crisis. And this was seen in an article by Duncan in 2018, which stated that many homeless individuals who were encountered during vaccination efforts expressed distrust of vaccines and vaccinators, whereas others believed they could keep themselves clean and therefore were not at risk. An article by Metcalf and Sexton discussed similar findings. However, a survey on opinions and behaviors related to vaccine providers by Grampenstein demonstrated that individuals vaccinated at traditional sites, such as physician offices and public health clinics, felt vaccine providers had more experience and they trusted them more as opposed to untraditional settings. This was also supported from a study by Polis where the identified clinic demonstrated a well-established history of acceptance and utilization by the homeless group, hence suggesting that familiar surroundings and provider trust are an important factor to increase vaccine coverage among the homeless. Criteria 7. Is there important uncertainty about or variability in how much people value the main outcome? We said we were uncertain. There were not many studies specific to the homeless on valuing the protection of disease, but several studies have shown that persons experiencing homelessness have high rates of hospitalizations and deaths, thus making necessary vaccines both available and accessible to highly vulnerable homeless is a critical public health issue. I would like to re-emphasize the study from Polis here, where the identified clinic showed a well-established history of acceptance and utilization by the homeless group. Criteria 8. Is the option acceptable to stakeholders? We said yes. Recent hepatitis A outbreak investigations in all 12 states have been supported by stakeholders and have raised awareness of homelessness among local officials. An article by Duncan looked at hepatitis A outbreak in San Diego County, where community clinics vaccinated approximately 7,500 adults in 7 months. There was a strong support from executive leaders and public health officials, which resulted in partnership with public health nurses who took hepatitis A vaccine to homeless encampments. A study by Nelson mentioned a budget being passed in Seattle, which increased homelessness spending to $67 million, a 60% increase over the past 4 years. The James study demonstrated that emergency department made a significant contribution in stemming the outbreak in Boston, where strong leadership and buy-in from emergency department personnel and hospital stakeholders were credited for the program's success. And finally, a study by Thorburn in 2001, which looked at drug users and food handlers, where the homeless group was combined with the drug user population. The Washington state legislature appropriated $300,000 for a vaccination campaign in jurisdictions who experienced a hepatitis A epidemic. Criteria 9. Is the option reasonable and efficient allocation of resources? We said probably yes. After action reports of hepatitis A outbreak investigations that are currently occurring in the United States showed outbreak campaigns entail huge costs. Medical costs, productivity loss, and it also causes not only disruption of the public health services and diversion of public health resources, it also involves extensive human resources. The San Diego outbreak reported the cost of responding to hepatitis A outbreak was approximately $12.5 million, whereas the cost of routine immunization through clinics are likely to be lower per capita compared to these rapid outbreak campaigns, as seen and discussed by Dr. Nelson already. During the multi-state hepatitis A outbreak that occurred in 2013, Epstein stated that outbreak-related hospitalizations associated with chronic medical conditions resulted in substantial healthcare usage and loss of productivity. A study by Belek mentioned that routine childhood and catch-up vaccination was a cost-saving measure in communities experiencing periodic outbreaks, such as the American Indian reservations and Alaskan villages. Furthermore, a national study of emergency departments showed that overuse of emergency services leads to higher treatment costs, and homeless individuals are more likely to be transported to the hospital via ambulance, further increasing treatment costs. And a meta-analysis study stated that the cost of liver transplantation could rise to about $160,000, which could be preventive if the individual was vaccinated with hepatitis A. It has been seen that vaccination based on housing status may be simpler than vaccination based on disclosure of behavioral risk factors such as MSM and persons injecting drugs. However, an adult immunization coverage assessment by Walter showed that less than 10% of adults aged greater than 19 years who had an indication of hepatitis A vaccine had been vaccinated. And finally, a study by Corner that demonstrated that even though hepatitis A vaccine is licensed in certain high-risk groups, cost-effectiveness data on its indications are very limited. Criteria 10. Is the option feasible to implement? We said yes. Health departments, emergency departments, community health centers, and primary health clinics are examples of effective venues for conducting immunization campaigns against vaccine-preventable diseases. Providers have demonstrated ingenuity and perseverance in ensuring that uninsured adults have access to vaccine and vaccination services. An ASTRA report in 2016 on identifying strategies on vaccinating uninsured adults stated that integrating immunization assessment, screening, and vaccination into the routine clinic flow is important for a program to achieve success. Organizations like the National Healthcare for the Homeless Council, who are working to make healthcare for the homeless more accessible, are advocating and presented on more states to increase Medicaid expansion, which may provide an opportunity to increase hepatitis A vaccine coverage among persons experiencing homelessness. Furthermore, a study by NIAMETI investigated the feasibility of hepatitis B vaccination program among the homeless in Los Angeles County. The study concluded the use of vaccination programs along with nurse case management is critical in completing a 6-month Twinrix series. The James study in Boston demonstrated that targeted vaccination at the emergency department following an hepatitis A outbreak was feasible. And finally, the Polar study, which you have heard repeatedly, discussed a successful vaccination program among the homeless population was seen in a clinic setting. This slide looks at studies on the uptake of other vaccines in the homeless. The first study we found for influenza vaccine was a cross-sectional survey conducted at 27 homeless hostels in London. The study concluded that influenza vaccine uptake was lower than the national level for all clinical risk groups that were identified. The second study by Wiseman in New York City looked at zoster, tetanus, and pneumococcal vaccine. It was a retrospective observational study at a federally funded clinic. The study reported higher uptake of vaccines among the homeless versus the general population, suggesting that homeless adults are accepting of routine vaccination. So in summary, should routine inactivated 2-dose hepatitis A vaccination be recommended for protection against hepatitis A among persons experiencing homelessness? When we looked at the balance of consequences, we said the desirable consequences of routinely vaccinating the homeless individuals for hepatitis A versus vaccinating during an outbreak clearly outweighs undesirable consequences, such as hospitalizations and deaths in most settings. Hence, we recommend the intervention and conclude that the benefit that we achieve by vaccinating homeless individuals is significant, and the cost and risk of vaccinating the homeless is much lower versus not vaccinating the homeless individuals. The next few slides are references. I would like to acknowledge Dr. Mark Wing for providing assistance in the evidence to recommendations framework and the grade analysis. And I would also like to acknowledge the ACIP Workgroup members, the CDC Division of Viral Hepatitis, the State Health Department, and the San Diego County of Health and Human Services. Thank you.
Great, thank you very much. We'd like to first see if any of the voting members have questions or comments on the past two presentations. Peter?
Hi, thank you. Very nice presentation and a really great example of grade.
Thank you.
This makes sense to me. It strikes me that the big issues are going to be feasibility and practicality issues for this population. So I do have a couple questions. Maybe first a comment. The issue about Medicaid expansion, this doesn't change the grade in my mind, but it's threatened with work requirements in 3 states, 7 to 9 states already applying for work requirements. this is a population that may lose the Medicaid. It doesn't change grade in my mind, but it has to do with the practicality issues. But I do have a couple other practical questions. Do we know about hepatitis A vaccination rates among youth who are homeless? There's 40,000 across the United States.
I do not.
There's no data?
No, we couldn't find any data specific to that.
And you mentioned other vaccinations. Do we know about hepatitis B vaccination status among the homeless population? Again, I'm thinking about the practicality issues.
Right. For our review, we really didn't look at hepatitis B with homelessness, but that's a good thing. We would consider looking at that.
And maybe one final point about practicality. Tracking is going to be really important in terms of whether this is state immunization registries or some way of tracking this population who many won't remember that they were vaccinated.
And the work group did mention that as a concern, and tracking as well. Potentially will be improved with changes in immunization services information systems as they improve over time.
Dr. Walter?
Yes, I too think this makes sense. I did have a question. Do we have any idea of the proportion of people who are homeless who admit to being homeless? Is there any data on that?
I'm sure it will be in the census.
Yeah. So the survey that's done one night every year, that gives is the best indication we have of how many are homeless at one given time. But in terms of whether they're admit to it or just observed, I don't know the answer.
I think it becomes an important issue if you're a provider in a clinic and recognizing who may or may not be homeless when you're taking care of them. So,
thank you. Dr. Hunter?
Yeah, Peter, I was wondering about your question about whether people are going to qualify for Medicaid or not, because if they don't, then they become uninsured, then they're covered by 317 funding, which is a implementation issue because you have to do it through a local health department, but they're still covered. Were you considering that?
Feasibility issue. They're covered for vaccine, but it's just a feasibility issue.
Dr. Stevens?
I had a question about the herd protection variability of the vaccine. Can you comment on differences? It seemed like there was a significant herd protection effect with 10% in some populations, yet other populations that required 80% protection. And I didn't quite understand, is there any data on those differences?
Sure. The 80% protection was stopping an outbreak, where the other studies that I showed, the 10% were implementation of routine vaccination and seeing a decrease in incidence of cases. So really two different questions there.
Dr. Messonnier?
Yeah, I just want to go back to what Peter asked about tracking, and that, we completely concur that tracking will be a problem, and there are no systems in place federally or at states or locally that are going to solve this problem. It's also true, though, that a single dose is sufficient in most data to stop an outbreak. And I think when ACIP makes this kind of recommendation where there are complicated issues around implementation, you could make a recommendation and then provide some context, then looking to CDC to provide those, what I would consider to be clinical guidance to help state health departments who are going to be the ones that are going to have to decide how to implement such a program.
Dr. Moore?
Thank you. Thank you both. And one thing I will add with the immunization information systems is that 42 or more of them are lifelong immunization registries at this point, and is as part of the outbreak response in the multi-state outbreak, there's been a much greater emphasis on reporting hepatitis A doses administered to adults as part of this outbreak across the U.S. and demonstrating to many new people the benefits of recording adult immunization in registries and checking that prior to immunization. And we've used that tool, as have other states, to reduce unnecessary excess immunization as outbreak response. So there is hope that state health departments and our partners in clinical settings are working on this with reporting to registries and checking registries for adults as well as children.
Great. Dr. Bernstein.
I had a question about the definition of homelessness, which we used here, but the studies that were graded, 3 of the 4 were outside of the U.S. Are their definitions comparable to ours, or are they, because the outside populations, their average age was 46 or 44, where the small study in the U.S. was an average age of 21 or at least 21.
Right. So if you looked at the seroprevalence studies, and if you looked at even like the POLIS study, which was the only study which was a clinical trial, they have been done outside of the United States. But if you looked at the age criteria by just looking at the seroprevalence and about the homelessness, it was the similar age group that was found. And regarding the definition of homeless, I think that is something we haven't really looked at it from the international perspective. But within U.S. itself, there are different definitions for homeless. There is a HUD definition, and there is the one from HHS.
Great. So we're going to move to questions from around the table. Dr. Freihofer first.
Sandra Freihofer, American Medical Association, and I applaud the work group's evidence-based recognition of homelessness as a risk factor for hepatitis A. The AMA has a new initiative dedicated to health equity, eliminating health disparities, encouraging more research and data collection, and influencing determinants of health, and identifying tools to help physicians identify at-risk individuals. This recommendation is specifically in line with new AMA policies to improve the health and well-being of people facing homelessness. And certainly this increased risk of hepatitis A is a good example of how social determinants, how we live, work, learn, and play affects our health, and how hepatitis A vaccination can make a difference. But back to the tracking, a reality check, completing the series. One of the background slides, I think is slide number 12, gave some data about one dose efficacy, but are there any more details or references on effectiveness after one dose? Because I think there's a concern that maybe some of these patients will not complete the 2-dose series, and what can we do to help that?
Yes, the study that I presented was by Ott et al. Back in 2011. There's not another study that looks at long-term protection after one dose. However, based on modeling and based on experience and lack of vaccine failures, we do believe that the one-dose protection is likely much longer, potentially even lifelong, but likely longer than the 11 years that I presented.
Great. Thank you. Dr. Natalski?
Thank you, Mark Natalski, AHIP. I'm curious about the population that may have been recently homeless or intermittently is homeless, but not at the time that they're evaluated. Should they still be considered at risk and part of this population? It gets to the definition of homelessness and whether or not when you're seeing them, if they are not,
Right.
should you still consider them at risk based on their past history?
So the work group looked at homelessness, including all the definitions of homelessness, from transient to unsheltered chronic. So all of the groupings that I showed on the slide from HUD should be considered as homeless and potentially at risk.
Dr. Ju Shen has a question next.
Hi, thanks. Jeff Duchin from National Association of City and County Health Officials. Very much support the recommendation to administer hepatitis A vaccine proactively to homeless persons. And I wanted to ask about two things. One is, do we know anything about unsheltered versus sheltered homeless? In Seattle and King County, we have approximately 12,000 persons who are homeless. It's a very large number, more than most states. half of those folks are living unsheltered, and we're most concerned about the spread of hepatitis A and other infectious diseases. We've had outbreaks of Shigella, we've had cases of Bartonella, we have HIV infections among homeless population right now who don't inject drugs. So my question is, do we know anything about the risk in unsheltered versus sheltered homeless? And secondly, I think that providers need to take into consideration the risk for homelessness. Someone who is transiently housed but has been chronically homeless or has risk factors for homeless. We have to remember, for instance, our sexual minorities, LGBT, trans people have a higher prevalence of homelessness. About 20% of people who are transgender have or will experience homelessness, for example, during their lifetime. So those issues, I think, are really important to place in context when you make your recommendation. And I'd also like to see some more guidance for emergency departments on how they can more effectively administer vaccinations to homeless persons, because it's quite challenging, I think, for them, and as much support and guidance as we can give them to do this effectively would be very valuable, because many homeless persons seek care in emergency departments.
Great, thank you. I saw Dr. Kimberlin's hand next.
David Kimberlin, AAP Red Book. I'm concerned about the variability in the definitions of homelessness. A family whose primary breadwinner loses their job, they're kicked out of their apartment, and they crash on a neighbor's couch for 3 weeks is homeless. That's not the same as someone who is on the streets and spending the night in shelters. And I really think we're talking about a very broad group of people who find themselves in certain circumstances in life. I'm not sure that this recommendation applies across that entire spectrum.
Thank you for those comments. So the main drivers that we've found in these outbreaks for transmission have been persons that are engaged with close contact to one another, poor hygiene. So we could certainly consider a recommendation that just relied on persons who are clearly homeless. However, it's hard for a provider to also make that distinction. Was one of the concerns, between someone who claims to be homeless, who is transient or couch surfing, as you suggest, versus someone who's out on the streets.
But isn't the risk for the people that are on the streets? I mean, isn't that so maybe that should be part of this recommendation?
Right. The other concern is about people that are going from couch to couch. Let's say if they're engaging in other activities such as drug use, which is already an indication for hepatitis A vaccine, there could be other additional risk factors that come to play.
This is Sharon Fry. I just wanted to make a comment about the concern of transient homelessness, even the people who are sleeping on their families' couches or neighbors' couches. We don't know, we cannot be certain how long somebody might be homeless. It may be the intent to find a new job, but we don't know if those individuals will eventually be successful and how long their period of homelessness will truly last.
Dr. Moore?
Thank you. Dr. Kimberlin, the work group certainly discussed the fact that there are variable definitions of homelessness, and certainly within those definitions, certain populations are going to be more at risk, more vulnerable than others, but it was felt that using an HHS standard definition that was broad and allowed for clinical judgment to be exercised would be most valuable, and especially given that the focus of implementation of a recommendation like this would likely be on clinics that routinely provide services to the homeless through HRSA funding and other things, that would be the implementation focus around that would often hit those, hopefully, who are most likely to be homeless for the longer term. Someone who's homeless for 3 weeks is unlikely to come to medical attention as needing a vaccine. So for practical purposes, we felt like the broader standard definition that was widely accepted would be useful here.
Great, thank you, Dr. Messonnier.
Yeah, maybe just to follow up on what a couple of you are saying. We value and work towards really precise, simple recommendations. But is it the intention of the work group in the ACIP statement to provide more of this context about, in other ACIP recommendations, y'all have been precise about whose responsibility it is. So the mumps recommendation, which you also did, squarely put the responsibility on the health department. In this recommendation, is there surrounding language that makes it clear that the intention of the work group is for the focus to be on the implementers of routine care to the homeless?
That was our discussion, and as far as the detailed guidance that goes into the recommendation, we can elaborate on that because it's a very good question that people will have, and we think we recognize that transient housing, unstable housing is very difficult to predict for anyone, and so we can provide guidance in the note that further elaborates on who we consider to be most at risk and most critical to receive this.
We have a comment from Dr. Morris in the back.
Yeah, thanks. Sorry, Supna Morris. I'm serving as the incident manager for the Hepatitis A multiple state outbreaks currently. And I happen to have a background in working with Healthcare for the Homeless and serve as kind of a SME for the center on this topic. So I do want to just clarify a couple of things. So number one, HHS and HUD have really aligned their definitions. They're very, very close to not exact. And so we've been, for a few years now, using relatively the same definition. Secondly, HUD manages a federal homeless management information system. So there's a very good tracking of homeless individuals. I'm not saying that that's tied necessarily to immune registries, but there's a lot more sophisticated tracking of people who are reporting homelessness than it may otherwise be apparent to most of us. And that's done, and there's a count that's done through the homeless management information system. So given that most people that are reporting homelessness are homeless less than a year, we can look at the point in time count, which is about 550,000 a year. But if you look at the individuals who experience homelessness in a given year, it's closer to about 1.1 million to 1.5 million. And of course, those numbers are, variable, but they are able to deduplicate and look at the individuals who experience homelessness. In terms of chronic and unsheltered versus sheltered homelessness, one could argue that unsheltered have a risk because of the lack of access to hygiene and access to care often, but sheltered also have a risk. We see a lot of infectious disease spread in congregate settings with very few bathrooms, with shared airspace. I work a lot in tuberculosis on this topic, and we have our tremendous problems in sheltered communities, and we see a lot of infectious disease that can spread in shelters. So in large congregate shelters, we still have the same issues as I think we would see in unsheltered, particularly in those living in encampments. HHS is a whole special work group that's now working on with the United States Interagency Council on Homelessness on doing specific work around targeting decreasing infectious disease in encampments and how we can improve hygiene in encampments. So there are a lot of groups that are working specifically on these issues. And I do want to just point out that it's hard to, I agree, vary the risk. And in terms of people reporting that they're homelessness, in terms of how Healthcare for the Homeless clinics deliver their care, they take broad definitions and people have no problem reporting they're homeless. Where you see the lack of report is in emergency departments or other clinical settings where someone may be couch surfing. And when they've broadened the questions to how many addresses you've had in a year, we don't have a problem. And so there's been a lot of recommendations through the council to use that as a further definition. So just to alleviate some of these concerns that you have, the care that's delivered by National Healthcare for the Homeless Council clinics, 300 of them across the country, is tremendously robust, and they get their supply of vaccine through their clinics' ordering system. So they vary it based on what their population is seeing. So in terms of actually whether or not the Medicaid expansion states, for example, in Georgia, I work for our Healthcare for the Homeless clinic here. We're not an expansion state, but they're able to adjust their ordering through 340B and 317 and all those kind of venues in order to get the supply that they need for their populations. So just want to make those comments. Thank you.
Great, thank you so much. That was really helpful. If there are no further discussions about these two presentations, I think we have a short presentation to discuss the language of a recommendation, of proposed language.
Now we'll discuss the considerations for use of hepatitis A vaccines for routine vaccination of the homeless. Policy question: should routine inactivated hepatitis A vaccination be recommended for protection against hepatitis A among persons experiencing homelessness? And just to review again, the current ACIP recommended risk groups with the proposal to add homelessness to the list. As Dr. Deshani presented, the grade analysis showed a evidence type 4 for reduction in disease burden and evidence type 4 for adverse events, with very low quality of evidence for adverse events. Desirable consequences clearly outweigh undesirable consequences in most settings. And the question: should routine inactivated 2-dose hepatitis A vaccination be recommended for protection against hepatitis A among persons experiencing homelessness? Was that we recommend the intervention. As Dr. Moore mentioned in the introductory talk, the Hepatitis Vaccines Workgroup is convened for 4 teleconference meetings on this topic and has reached consensus regarding the proposed update to the hepatitis vaccine statement regarding homelessness as a risk group for hepatitis A vaccination. Workgroup considerations around homeless as an independent indication for hepatitis A vaccination are as follows. Homelessness might be a proxy for high rates of known risk factors, example, chronic liver disease, drug use. However, these risk factors might be more difficult to identify than homelessness itself. In San Diego, a currently recommended indication for vaccination was not found for greater than 25% of homeless cases reporting risk factors. Workgroup considerations regarding the risk of infection and severe manifestations among the homeless are as follows. Homeless are more vulnerable due to poor hygienic conditions and overcrowding. Once hepatitis A virus is in the homeless community, it spreads because of poor sanitation, poor hygiene, and congregated living conditions. Homeless have an increased risk of severe disease, hospitalization, and death. Vaccinations are critical to the prevention of disease outbreaks and epidemics among individuals experiencing homelessness because of their poor living conditions conducive to hepatitis A virus transmission. Workgroup considerations regarding routine 2-dose hepatitis A single antigen vaccination are as follows. I will point out that Twinrix is an available option for vaccination of the homeless. However, the discussions around 2-dose single antigen vaccination were because we were discussing whether comparing it to 1 dose, the 2-dose is the currently recommended schedule and also follows the FDA and manufacturer recommendations. So the FDA licensed schedule and ACIP hepatitis A vaccine routine recommendations include 2-dose vaccination. If homelessness is included as an ACIP indication for vaccination, vaccination is more likely to be considered by homeless service providers. Evidence that homeless in San Diego are returning to care for a second dose is apparent. 1-dose single antigen vaccine is highly effective, provides up to 11 years of protection, and might provide lifelong immunity. However, considering the immune and health status of homeless, 2 doses is optimal for long-term immunity. The homeless population is not stable, moves from place to place. The outbreaks that are presented today are not all related. The California outbreak is genotypically linked to the outbreaks that are in Utah, Kentucky, and other states. So it is important that we take a national approach to vaccinating homeless. Integrate vaccination into services for the homeless over time, reduce the at-risk population, and therefore reduce the risk of large-scale outbreaks. Vaccination will increase the herd immunity among the homeless population over time. Vaccine administration record keeping was a workgroup concern, but it was felt that increasing use of immunization information systems for adults, future advances in interoperability would address this concern and should not be a reason not to vaccinate routinely. Workgroup considerations regarding pre-exposure prophylaxis versus post-exposure prophylaxis in outbreak situations. Vaccinating homeless in an outbreak setting is very challenging. Resources involved are enormous, the population is hard to reach, and the efforts required to vaccinate are vast. Vaccination of homeless in outbreak situations result in vaccine hesitancy due to the emergency situation, unanticipated event, rushed health care, and limited time for education and understanding of the situation. Effective post-exposure vaccination is difficult, including obtaining exposure history and coordinating vaccination within 2 weeks of exposure, which is required for post-exposure vaccination. It's difficult to control outbreaks among homeless quickly. The longer it takes to vaccinate, the higher the probability of breakthrough cases and spread to other jurisdictions. Routine vaccination is a more feasible approach to reach homeless over time through homeless outreach organizations. And this can occur through gradual implementation. Barriers to vaccination might be mitigated with a routine recommendation, and more opportunities to reach people in settings where they are comfortable with greater use of homeless advocacy groups. Routine recommendation would allow for vaccination of homeless by trusted providers who serve the homeless in familiar settings. Workgroup considerations regarding the individual homeless person. It is important to recognize the individual homeless person because they are at higher risk than other groups. High hospitalization and fatality rate in these outbreaks occur at an individual level. People experiencing homelessness have difficulty implementing recommended non-vaccine strategies to protect themselves from exposure. For example, clean toilet facilities and the ability to wash their hands regularly. For this reason, they depend more heavily on vaccination for protection from hepatitis A infection. Due to limited access to health care and state-to-state variation in access to insurance coverage, homeless adults can be more vulnerable than other adults to vaccine-preventable diseases. Workgroup considerations regarding cost. The outbreaks have demonstrated the enormous cost and difficulty associated with trying to do widespread immunization of a large vulnerable population in a short amount of time. High hospitalization rates among vulnerable populations drives up cost. Cost per capita of integrating vaccination into routine care is cheaper, much less disruptive than vaccination solely as part of outbreak response. And outbreak responses cause substantial diversion of human and financial resources from other activities in many affected jurisdictions. The workgroup consensus is as follows. Homelessness should be an indication for hepatitis A vaccination. Homeless persons could benefit from a specific recommendation for routine hepatitis A vaccination. Recent outbreaks have demonstrated that individuals who are experiencing homelessness have an increased risk of serious illness with hepatitis A and face barriers to implementation of alternative strategies to prevent exposure, such as strict hand hygiene due to their living conditions. A routine recommendation would allow homeless to be vaccinated using the services and facilities that already provide established health care for the homeless population. Routine hepatitis A vaccination of the homeless would allow for integration of vaccination into these services over time towards reducing the hepatitis A viral infection risk of this vulnerable population and reducing the risk of large-scale outbreaks. I'll now present the pros and cons for homelessness as an indication for vaccination versus no indication for homelessness. The pros are protection of a vulnerable population. Providers are more likely to administer vaccine to homeless persons if homelessness is an ACIP recommended indication for vaccination. Vaccination of homeless persons would reduce an at-risk population and therefore reduce the risk of large-scale outbreaks, increase the herd immunity among the homeless population over time. Vaccinating homeless in an outbreak setting and controlling an outbreak among homeless is challenging compared to integrating services into a familiar setting. And routine vaccination is likely less costly than vaccination as part of an outbreak response. The cons, as mentioned, potentially vaccine administration record keeping. Limited published data exists on hepatitis A or vaccination that specifically focuses on persons who are homeless, as Dr. Deshani just described. And routine vaccination of homeless who do not utilize health services might not be feasible.
Great, thank you. Any further discussion or comments from the committee members? Do you want to put the language up that you would like the committee to consider?
Sure. The vote language is as follows. All persons aged 1 year and older experiencing homelessness should be routinely immunized against hepatitis A.
So would anyone like to make a motion to vote on this proposed language? Dr. Lee made a motion.
Second.
I'll second. Fighting to second it. Dr. Moore seconded it. Great. Well, we will try the electronic voting, which we worked on prior to the opening of the meeting.
Amanda, we're going to do comments first.
Oh, I'm so sorry. Okay, so we do actually have several public comments. Please, committee members, see the one written public comment from the County of San Diego, Dr. Wilma Wooten. It's included in the back of your hepatitis section. Additionally, we do have some comments specifically related to this hepatitis vote. The first person I'd like to call is May Morgan, please.
Good morning. I'm May Morgan. I'm the Chief Medical Officer for Mercy Care, which is a community health center that focuses on health care for the homeless. Pretty much my comments have already been stated. Thanks, Dr. Morris, and have been covered during the session. Just wanted to add that for anybody who's concerned that there's not a network in place, there are several community health centers. I can speak to the Atlanta area. In this area, which provide services for the homeless, but we are the primary provider. Out of the 45,000 visits that we had last year with 1,600 unique visits, about 68% of that population was homeless. So because we are a HRSA-funded agency, not only is general health care expected, but also preventive care. So we have procedures that are in place that address that. We not only work as community health centers and with the other community health centers in the area, we also work with the health departments, with the Safety Net Hospital, and also have an HIE where many of us can see each other's health records. This state also has a registry for immunization documentation. Two issues. I think if this is voted, what it does is gives a heightened awareness to providers, whereas we do prevention. You know, you hear a lot about hepatitis B, and we often use Twinrix to address both issues. We also have a high hepatitis C population where vaccination is indicated as well. I've been doing this for 12 years. My biggest issue, and I've always focused on preventive care, is the cost that's associated with it. We do get a little bit of break for purchasing vaccines. However, the focus has been on those that are already recommended on a regular basis. And if we did have an outbreak, it would just be difficult to rise to the occasion and address that issue. So I think costs, just across the board, is something else that needs to be considered as well. And I think with this being a recommended vaccine, then we can tap some of the resources that are not available currently. Thank you.
Thank you, Ms. Morgan. I have two additional individuals I believe are signed up for public comment. Denise Aguilar and Jamie, Jaren. Do either of you have a hepatitis A comment to make?
Yes, please. Hi, I'm Jamie Juarez. Thank you, everybody in attendance here and online. And I wrote this on the cusp, so hopefully I do okay. So I'd first like to address The variables related to homelessness in children and our veterans especially. Of course, thank you to our military. It's personal to me. My dad was airborne in Vietnam, and my mom graduated from 1978 in the Air Force Academy. She is currently one of the highest ranking women in aviation. So thank you to our military. And I'd like to include that I didn't see statistics, especially in San Diego, where I am from Southern California, that there's a 45% increase in homelessness in our veterans there. And I think that that data is pretty relevant when it comes to issues like this. But my concern in particular here is the ethical obligations to the benefits and harm data that was presented. It appears that a lot of this data lacks independent versus dependent variable analysis. There's over, especially when you combine hepatitis A in conjunction with other vaccinations. We looked at the vaccinations in combination, and there's over 440 ingredients in these vaccinations, according to the schedule. So I think it's pretty relevant when we're looking at data that we include those types of, looking into that, especially when it comes to longitudinal data. I didn't see any of the studies showing any longitudinal data. They were mostly observational, and I think that's a big concern when it comes to the recommendations by the committee. And the response to the data that looked at youth, I think that there is data on youth. I think it's relevant when we look at the school districts and particular social service programs. So I think that the question asked about data in youth is relevant, and I'm disheartened by the fact that that wasn't included. And then lastly, of course, we need to look at the World Health Organization's Code of Conduct, because I do believe that there's a lot of irresponsibility in the way that we're conducting these studies and looking at the meta-analysis approaches. So thank you.
Thank you very much. Do we have anyone else who would like to make public comment prior to the hepatitis A vote? Denise? Are you Denise? Great.
Thank you. My name is Denise, and I'm from California, where we have these large outbreaks. These large outbreaks are partly because there are no facilities for homeless people to go. We have one facility, and for a large population of 300,000 in a city, this is a problem. From the numbers that I saw up, it was going to cost $28 and some cents per dose of vaccines. I would just like to know, I'm sorry, I just ran from the bathroom. I would just like to know, has anybody ever looked at the cost of putting in bathrooms and sanitation practices in these neighborhoods instead of a mass vaccination? It seems that from the one study that was done and the multiple studies, that sanitation practices would be a better fit than a mass vaccination for people who are not trackable. These are homeless people, and it's impossible. They move around. So how are you going to actually implement something like this? So that's my concern.
Great, thank you all. I believe if that's it for the public comment, we have a motion on the table and it's been seconded, so we'll go on to the vote. So everyone, electronic voting attempt, number 5 or 6, maybe just 3. Is this the language? Great. So the 3 options are to vote yes, no, or to recuse. I just want to remind everyone that there were no conflicts announced at the beginning of the meeting, so the voting is now open. Well, we got all of the votes. Is that real? Great news. Okay, excellent. Thank you. Yay. Okay, so this vote passed. 100% of the members voted yes. We have discussed going around the room and just having each member confirm that they did make the vote that they put. So can we start with Dr. Welcher?
I voted yes.
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 Atmar, yes.
Bernstein, yes.
Zanolo, yes.
Stevens, yes.
Moore, yes.
Salaji, yes.
Lee, yes.
Romero, yes.
Great, thank you. Well, with the conclusion of that session, we have a break, and I believe we're a little bit ahead of schedule. Oh, excuse me. Oh, I forgot. We have a VFC vote and resolution change, right? I'm so sorry. So Dr. Santoli is going to discuss an update to the Hepatitis A VFC resolution.
Peter. And this
update actually does not have anything to do with the discussion that you all have just had, because universal vaccination for children is already covered, and so the risk groups are not called out. So it's going to be a bit of switching gears. So the purpose of the resolution is to correct and streamline language related to catch-up vaccination. And this is language that was voted on in the February meeting. The parts of this presentation that are in yellow is where there's a change. Everything that's in white means the language is exactly the same. So the eligible groups remains unchanged. I'll give you a minute to look at that. But with the recommended vaccination schedule, you'll see we had two different sentences about catch-up. We didn't need to. They overlapped, and there was an error in one of them. So we combined them into one. And so what you see is the change to one of those statements where we just add through 18 years of age.
Is that the end?
And that's it.
Oh, okay.
The rest
Great.
of it,
Okay.
just to show you, it's all white language, which means it's not changed. So,
Okay.
thank you.
So we are asking for a motion to update the language to clarify the catch-up through age 18 years. Dr. Fry has made a motion. Dr. Szilagyi has seconded. Do you want to put up the slide? And then do we have any public comment prior to this language being updated? It doesn't appear so. So we will go ahead and put up the language, or put up the vote slide. Okay, so we'll do electronic voting again. Please vote. Members, voting is now open. Is it not working?
No. Amanda.
Okay. Okay, so we will go ahead and do around the table voting. We also are running into is it now reset? It's okay. So we'll go ahead and vote around the table because the computer wants to reset as well. So we need to get on to break. We will start with Dr. Walter.
Walter, yes.
Hunter, yes.
Fry, yes.
Atmar, yes.
Bernstein, yes.
Zanolo, yes.
Stevens, yes.
Moore, yes.
Szilagyi, yes.
Lee, yes.
Romero, yes.
Great. So we have 11 yeses and 0 noes and 0 recusals. So that is complete, which means now I believe we can go on to break. It is 10:05. Our break finishes at 10:30, I believe. Yes. And I think that we can go ahead and just reconvene at 10:30. I do want to make a couple comments about the room. I see that there's a lot of people standing in the back, and I think if people in the back two sections would please scoot closer together, we could make more room for individuals sitting in the back. We've also designated these two side areas at this meeting for CDC staff and ACIP workgroup members, and we'd appreciate y'all members of the public and other organizations, please sitting in the back two sections of the room. Please, let's try to make room for everyone to sit after the break. Thank you.